This is the gross appearance of Wilms tumor, gross appearance of Wilms tumor. So over here you can see that there is a very large single mass as we can appreciate over here, a very large single mass as we can appreciate. It is quite well circumscribed as we can see, and they are weighing more than 500 gram. So the cut surface as we can see, they are grayish pink in color and they are solid and soft, homogeneous in appearance. Now larger tumors, they can have some foci of hemorrhage as we can appreciate from this diagram. This is the focus of hemorrhage, and over here this is the focus of necrosis. So larger tumors can develop focus of necrosis as well as hemorrhage as we see in this diagram. And as you already see over here, the viable renal tissue or the kidney, it has been compressed. Okay, it has been compressed. So this is your compressed renal tissue over here. Okay, there is a compressed renal tissue as we can appreciate in this diagram. So coming to the microscopic examination of the Wilms tumor, as we can see, this is the first element, that is the blastemal element. As you can see that there is a classical sheets of small round blue cell, small round blue cell, which is constituting the primitive blastemal component. The nucleus is hyperchromatic and there is frequent mitotic figures as we can appreciate in this particular diagram. So these are all the mitotic figures that we can see. So this is constituting the blastemal component of the Wilms tumor. The second important component of the Wilms tumor is the epithelial component as we see over here. Now the epithelial component over here, they are in the form of tubules. They are also resembling the primitive glomerulus. Okay, so the epithelium is, this is the epithelial component, and they are in the form of columnar epithelium, and they are forming the tubular structures. Coming to the third important component, that is the stromal component of the Wilms tumor. If you see the stromal component, so they are basically in the form of fibroblastic or spindle shaped cells. So this is the fibroblastic or spindle cell morphology. This is comprising or constituting your stromal component, and if you see the background is pale background, that is basically constituting the myxoid matrix or the myxoid background. Okay, myxoid background. So this is basically constituting your stromal component of the Wilms tumor. Myself, Dr. JIBRAN presents to you Simply Pathology, and today we are back with a very important lecture. We are going to discuss another high yield topic, and today is the topic number 8. So today's topic of discussion, as you have already seen the diagram, is Wilms tumor. Now Wilms tumor is one of the pediatric renal tumor. It is also known as nephroblastoma. It is the most common renal tumor of childhood. Very, very important MCQ. The peak incidence is approximately 2 to 5 years of age, and 95% of the Wilms tumor, it occurs in less than 10 years of age. Now approximately 5 to 10% of the Wilms tumor, they are bilateral in nature. Now this bilateral tumor can either occur synchronously or they can occur metachronously. Synchronously means the tumor basically developing at the same time. Both the tumors are developing at the same time, that is synchronous. And metachronous means one kidney will develop the tumor, and subsequently after some time the second kidney will also develop the tumor. So this is the meaning of synchronous and metachronous. So what are the features of bilateral Wilms tumor? The age of onset is slightly earlier. It is 10 months earlier than the tumors which are restricted to one kidney, and usually they harbor germline mutations. Okay, that means they are familial tumors. These are familial Wilms tumor. Coming to the pathogenesis and the genetics of Wilms tumor. Now it is associated with 3 important syndromes. The number 1 syndrome is called as the Vagar syndrome. Now Vagar stands for Wilms tumor, okay, aniridia, genital anomalies, and mental retardation. So the lifetime risk of development of Wilms tumor in patients of Vagar syndrome is approximately 33%. Now it is associated with germline deletions on one of the chromosomes 11p13. Another important MCQ. Now the deleted chromosomal segments contain 2 genes. One is your WT1 gene, that is the Wilms tumor 1 gene, and another is your PAX8 gene, which is basically responsible for aniridia. So they are also called as aniridia genes. Now WT1 normally it encodes a transcription factor that is critical for the normal renal and gonadal development. Now how they develop, basically if you see, normally there is a first hit that is in utero. Okay, so this is going to lead to germline mutation in the WT1 gene, that is the first mutation. Now this is followed by the second hit, okay, which is basically because of a frame shift mutation or a nonsense mutation, which is giving rise to what is called as a Wilms tumor. So this is all about the first syndrome, that is the Vagar syndrome. Coming to the second important syndrome over here is the Dennis-Drash syndrome, called as the Dennis-Drash syndrome. Now this has a very high risk of development of Wilms tumor. The risk is approximately 90%. It is characterized by two main anomalies. Number one, it can have gonadal dysgenesis characterized by male pseudohermaphroditism and nephropathy. Nephropathy is basically exemplified by diffuse mesangial sclerosis leading to renal failure. Now remember, in this syndrome of Dennis-Drash syndrome, okay, so there is a dominant negative missense mutation in one of the alleles of WT1, and this interferes with the working of another normal allele of the WT1, that is the wild type allele. And although one type of allele has the mutation, and the other one is normally functioning, but the missense mutation in one allele of the WT1 will interfere with the working of the normal allele. So only one single mutation is sufficient to cause genitourinary anomalies. So whatever anomalies that we have seen, that is very much common with this kind of mutation, but Wilms tumor doesn't happen with just a missense mutation in WT1. So for the development of Wilms tumor in Dennis-Drash patients, okay, it requires biallelic inactivation of WT1. So let me explain you once again. So normally patients of Dennis-Drash syndrome, okay, they have a dominant negative missense mutation involving one allele of WT1. Now this is going to interfere with the functioning of the normal allele as well, but this is only going to cause the genitourinary anomalies of Dennis-Drash syndrome, and it is not going to cause the Wilms tumor. For development of the Wilms tumor, there has to be biallelic inactivation of WT1 is required for development of Wilms tumor in such patients. Now these patients having this syndrome, they are also at an increased risk of development of one kind of a germ cell tumor called as gonadoblastoma. Coming to the third important syndrome, that is called as Beckwith-Wiedemann syndrome. Now this is characterized by enlargement of the body organs. So there is an organomegaly, there is macroglossia, hemihypertrophy, omphalocele, adrenal cytomegaly, and there is also a predisposition to develop Wilms tumor. Now the chromosomal region involved in this syndrome is your 11p15.5, and this particular region is corresponding to the WT2 locus. So this is distal to the WT1 locus. The basic genetic abnormality associated with Beckwith-Wiedemann syndrome is associated with genomic imprinting. So usually over here what is happening, there is a defective imprinting taking place. Imprinting means basically silencing. Imprinting means silencing. So this defective imprinting leads to an excessive expression of a particular gene called as insulin-like growth factor 2 gene, which is located in this deleted area, 11p15.5 region, this affected area. So this increased expression of IGF2 gene leads to overexpression of IGF2 protein, and which is responsible for your organomegaly as well as overgrowth, and also predisposes the patient for Wilms tumor. So this is all about the three important syndromes associated with Wilms tumor. Now coming to the sporadic tumor. So all these three syndromes that we have read, these are basically acquired mainly in the germline, and they are familial in nature. Okay, so in the families you can have these associated syndromes, but as we have already seen that 90% cases of Wilms tumor, they are sporadic in nature. Okay, the molecular abnormality is not studied extensively yet for the sporadic tumor, but with whatever amount we have read, we have seen that in case of sporadic Wilms tumor, only 10% patients with sporadic Wilms tumor, they are having mutation in WT1. So the 90% cases are having mutation in some other genes. For example, gain of function mutation in beta catenin is present in another 10% sporadic tumors. Other mutations which are involved in the causation of sporadic Wilms tumor, these involve genes which are encoding proteins involved in microRNA processing, like the DROSHA genes, DGCR8 genes, or DICER1 genes. Okay, so approximately 15 to 20% of the Wilms tumor, the sporadic Wilms tumor, they have involvement of these genes, and these have what is called as a blastemal histology. What is blastemal histology? It will be more clear further on in this video. So basically, because of mutations in these genes, there will be a decrease in the level of mature microRNA, especially the microRNA 200 family is involved. Normally, this microRNA, they are involved in mesenchymal to epithelial transformation during the renal morphogenesis or renal development. If there is mutation leading to a decreased amount of microRNA, then what will happen? There will be persistence of the primitive nephrogenic rest, also called as the blastemal rest. Now, tumors having TP53 mutation are associated with a poor prognosis, as well as they are associated with anaplasia. So, just to recall, Wilms tumor can present in two manners. One is your familial and another one is sporadic. 90% of the Wilms tumor is sporadic in nature, whereas 10% is associated with familial syndromes. So, there are three important familial syndromes associated, that is Vagar syndrome, Dennis-Drash syndrome, and Beckwith-Wiedemann syndrome. So these are all the syndromes associated with the familial Wilms tumor. In case of sporadic tumors, as I've already told, only 10% cases have the Wilms tumor. 10% can have gain of function mutation in beta catenin, whereas the other mutations can involve genes involved in microRNA processing, and this can lead to a decreased level of expression of microRNA, and the normal function of this microRNA processing is in normal renal development. If it is reduced, it will lead to persistence of the blastemal rest or primitive rest. Now, coming to the morphology of Wilms tumor. So, grossly, if you are looking at a Wilms tumor, these are very large tumors. They are solitary and they develop a false capsule, a pseudo capsule. So, they are quite well circumscribed. On cut section, they are soft, homogeneous, tan to gray with occasional foci of hemorrhage, cyst formation, as well as necrosis. So this is the gross appearance of Wilms tumor, So over here you can see that there is a very large single mass, as we can appreciate over here, a very large single mass as we can appreciate. It is quite well circumscribed, as we can see, and they are weighing more than 500 gram. So the cut surface, as we can see, they are grayish pink in color and they are solid and soft, homogeneous in appearance. Now, larger tumors, they can have some foci of hemorrhage, as we can appreciate from this diagram. This is the focus of hemorrhage, and over here this is the focus of necrosis. So larger tumors can develop focus of necrosis as well as hemorrhage, as we see in this diagram. And as you already see over here, the viable renal tissue or the kidney, it has been compressed. Okay, it has been compressed. So this is your compressed renal tissue over here. Okay, there is a compressed renal tissue, as we can appreciate in this diagram. Coming to the microscopic examination of the Wilms tumor, now there is a triphasic combination of three important elements. First is your blastemal element, second is your epithelial element, third is your stromal element. So blastemal cells or the blastemal component is nothing but it is the primitive component, and which is basically expressing itself in the form of sheets of small round blue cells. That is why this is also called as small round blue cell tumor, and it also comes under the differential diagnosis of small round blue cell tumor. Now the epithelial component, basically they present in the form of small abortive tubules or the glomerulus. Okay, this is the form that they present. And the stromal cells, usually they present as a fibroblastic or myxoid differentiation. Sometimes skeletal muscle differentiation might also be seen. Now sometimes there is a heterologous differentiation which is present in such patients. That means they will show squamous epithelium or mucinous epithelium. They might show other elements like smooth muscles, adipose tissue, cartilage, osteoid, and neurogenic tissue. So these are the heterologous differentiation that might be seen in some patients. Now 5% of the tumors might show what is called as anaplasia. Now anaplasia is defined as the presence of cells with large hyperchromatic pleomorphic nucleus and abnormal mitosis. And the presence of anaplasia is correlated with the presence of TP53 mutation, as well as they are correlated with a worse prognosis. They are correlated with having a worse prognosis. So let me just take you and describe the histological features, how it looks under the microscope. So coming to the microscopic examination of the Wilms tumor, as we can see, this is the first element, that is the blastemal element. As you can see that there is a classical sheets of small round blue cell, which is constituting the primitive blastemal component. The nucleus is hyperchromatic and there is frequent mitotic figures, as we can appreciate in this particular diagram. So these are all the mitotic figures that we can see. So this is constituting the blastemal component of the Wilms tumor. The second important component of the Wilms tumor is the epithelial component, as we see over here. Now the epithelial component over here, they are in the form of tubules. They are also resembling the primitive glomerulus. Okay, so the epithelium is, this is the epithelial component, and they are in the form of columnar epithelium, and they are forming the tubular structures. Coming to the third important component, that is the stromal component of the Wilms tumor. If you see the stromal component, so they are basically in the form of fibroblastic or spindle shaped cells. So this is the fibroblastic or spindle cell morphology. This is comprising or constituting your stromal component, and if you see the background is pale background, that is basically constituting the myxoid matrix or the myxoid background. Okay, myxoid background. So this is basically constituting your stromal component of the Wilms tumor. Now, as I told you, the stromal component, sometime predominantly there might be presence of skeletal muscle as well. Skeletal muscle as well, as we can appreciate from this particular diagram. And as I already explained that in 5% of the Wilms tumor, they can show large, bizarre, hyperchromatic cell, as we can see, and these are basically representative of anaplasia. These are representative of anaplasia. So some tumors can have very large, bizarre, dark staining nucleus and cell, and this is basically corresponding to an unfavorable histological category corresponding to worse prognosis. Another very important diagram which is showing anaplasia, as we can see over here. So multipolar mitotic or abnormal mitotic figures can be seen in this particular diagram. Nuclear pleomorphism is also seen in this diagram, which is basically constituting your anaplasia. This is again representative of anaplasia, which is associated with a bad prognosis. Now we want to understand about the concept of what is called as a nephrogenic rest. This is a very important exam viva question. So what is the importance of nephrogenic rest? It is regarded as a precursor lesion of Wilms tumor. It is present adjacent to the renal parenchyma where there is a Wilms tumor. So in approximately, it is present in 25 to 40% of unilateral Wilms tumor and in 100% cases of bilateral Wilms tumor. So what I am trying to tell you that if, for example, this is a particular kidney that we are watching and this is another kidney that we are seeing over here. Okay. This is another kidney. So for example, the Wilms tumor is present at this particular end. So in the nearby areas, there will be areas where there will be presence of what is called as the nephrogenic rest. So nephrogenic rest is present adjacent to the tumor. Okay. So approximately in 40 to 45% of unilateral tumor will contain nephrogenic rest, and if the Wilms tumor is bilateral, then in 100% of the cases you have the presence of the nephrogenic rest. So what is the importance of this nephrogenic rest? So one should always document the presence of nephrogenic rest in resected specimen, as these patients, they have an increased risk of developing Wilms tumor in the contralateral kidney. So such patients which are having unilateral Wilms tumor, they should always be under surveillance, under follow-up, okay, because there might be a risk of development of Wilms tumor in the contralateral kidney. Okay, and why we are saying that they are a precursor lesion of Wilms tumor? Because they have the same genetic abnormality as it is seen in adjacent Wilms tumor. So now we are going to discuss about your clinical features of Wilms tumor. So the most common clinical presentation of the Wilms tumor is asymptomatic abdominal mass associated with abdominal pain, hypertension, fever, all this in decreasing order of appearance. Now, the rarest clinical feature of Wilms tumor is hematuria. Other rare manifestations will include intestinal obstruction, and very common site of metastasis is your pulmonary metastasis is very common at presentation. Now Wilms tumor, if you see, 90% of the Wilms tumor, they are sporadic in nature, whereas only 10% cases they are familial, which is bilateral and multicentric in nature. Coming to the prognostication of the Wilms tumor, if you see, now, presence of anaplasia under microscopy is associated with a worse prognosis that we have already read about. Again, the presence of TP53 mutation along with resistance to chemotherapy can be correlated with anaplasia and associated with a worse prognosis. Molecularly, loss of heterozygosity at the chromosome 1p and 16q and gain of chromosome 1q in the tumor cell is associated with a bad prognosis. Okay. Now, increased survival of patients of the Wilms tumor. So because of the advances in the radiotherapy, chemotherapy, or because of the advances in the surgery, okay, so the chances of survival of the patients with Wilms tumor has become very high. So these patients who survive, okay, they develop secondary primary tumors or second primary tumors, like they can develop bone and soft tissue sarcomas, leukemias and lymphomas, or breast cancers. Now, why they are developing these tumors? Because of the radiation therapy they have received for the Wilms tumor. So we have to use radiation therapy very judiciously, and we should not overtreat the patient for Wilms tumor, because the radiation itself can be a risk factor for second primary tumors later on in their life. Coming to the last section of the Wilms tumor, very important is the staging of the Wilms tumor. So it is very, very easy. There are 5 important stages of Wilms tumor. The stage number 1 is when the tumor is confined to the kidney and is completely resectable, and it's completely resected. That is stage 1. Stage 2 is when the tumor extends locally, but yet the tumor is completely resectable. Stage 3 is there is a residual tumor that is left, and the tumor is confined to the abdomen without any hematogenous spread. The stage 4 is when there is hematogenous spread or there is metastasis beyond the confines of the abdomen. And the last stage, that is the stage 5, is a stage when the tumor is present in the bilateral kidneys. So thank you everyone for watching this particular video, and I hope you have gained a lot of knowledge from this particular lecture. Thank you very much everyone.